Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on treatment considerations for transgender people with HIV, featuring Dr. Michelle Collins-Ogle, who is an assistant professor of pediatrics in the Division of Pediatric Infectious Diseases and Pediatric and Adolescent HIV at Children's Hospital at Montefiore and the Pediatric Hospital of Albert Einstein College of Medicine in the Bronx, New York. She'll take us through a case study of a transgender person newly diagnosed with HIV. She will explore the latest data and recommendations for choosing ART for transgender people with HIV and discuss considerations for providing HIV care within a gender-affirmative care model. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Collins-Ogle.
My name is Michelle Collins-Ogle. I am an assistant professor of pediatrics in the Division of Pediatric Infectious Diseases, and I work in pediatric and adolescent HIV at Children's Hospital at Montefiore and the Pediatric Hospital of Albert Einstein College of Medicine in the Bronx, New York. And I'm going to talk with you a little bit about key decisions in HIV and treatment considerations for transgender people living with HIV. So I'd like to start out with talking about a case, and this is actually a patient that I provide care for. And so I'd like to start out with this because this is often what you'll face when you're taking care of young people that are transgender experienced. So this is a 22-year-old transgender woman who presents for a routine primary care visit. She's been on estrogen since about 18 years of age. Currently, she's on oral estradiol, 4 milligrams once daily. She's had no gender-affirming surgeries. And right now, she lets you know that she's separated from her long-term partner for 2 years and that she's having condomless sex with men. Generally, she's inconsistent with condom use, depends on the man. And she also tells you that she's anal receptive with all of her male partners. As part of your routine primary care, you do her STI testing, and you find that syphilis is non-reactive. Her 3-site testing for GC and chlamydia is negative, but her HIV 1-2 antibody are reactive. And you see the rest of her lab values there are normal, but you see her serum estradiol is 200 picograms per ml, which lets you know that she is adherent to her estradiol regimen, and her serum testosterone is 7 nanograms per deciliter. And what's not in here that I don't think is really important, that she is on androgen blockers. She is on spironolactone once daily as well. DHHS guidelines, recommendations for transgender people living with HIV, clearly states that ART is recommended for all transgender people living with HIV for personal health and to reduce HIV transmission. HIV care services should be provided within a gender-affirmative care model. We'll talk a little bit more about what that looks like during our presentation. And that when you integrate the care and that you're providing HIV care in the setting of gender-affirming care, that it reduces barriers to adherence, maximizes chances of sustained viral suppression within those individuals. And for individuals of childbearing potential, perform pregnancy tests before your ART initiation. Don't forget that even if you have a transgender male, if they haven't had any gender-affirming surgeries, they could potentially be pregnant. So make sure that you perform pregnancy tests on them, even if they tell you that they're not having sex with cisgender men. Remember, adolescents, young people don't always disclose all of their sexual activities and who their partners may be. So please make sure you perform pregnancy tests on all of your patients of transgender experience that have a vagina and uterus present. DHHS guidelines, recommendations for transgender people living with HIV show that ARV choice and considerations are the following. Some ARVs may have PK interactions with gender-affirming hormone therapy. So you want to make sure that you routinely monitor clinical effects and hormone levels. You also want to make sure you titrate your estradiol and testosterone and androgen blockers as needed. And then for gender-affirming hormone therapies associated with hyperlipidemia, elevated cardiovascular risk, and osteopenia, you want to make sure that you recommend ART regimens that will not increase the risk of AEs in those individuals. So providing care within the gender affirmative care setting, what does that mean? What does that look like? And what is gender affirming care? Remember that gender affirming care does not necessarily mean that the person that's of trans experience that you're seeing is on hormones or wants to be on hormones. So that gender affirming care does not equal hormone therapy. So make sure that in that setting, that you are understanding what gender affirming is for them and that you're meeting them where they are in that definition. You want to make sure that you're non-discriminatory and providing the care, that you're sensitive to gender affirming issues, and that you have some understanding and scope of the person in front of you, what their experience may be in trying to obtain gender affirming care. And again, what does gender affirmation mean to them? Does not always mean being on hormones. Make sure that you're, again, asking relevant sexual, mental, and physical health questions. I always recommend letting them know why you're asking those questions because some of the questions may seem very intrusive to them and very personal. Let them know that you want to make sure that you're asking these questions so that you're providing the best type of care for them and that you're helping them to protect themselves from other sexual transmitted infections as well. Medically affirming care that includes hormone therapy and referrals for gender affirming surgeries and procedures should be done in the same setting of the HIV care. Again, this allows you to have maximum adherence, and these patients are more likely to do well when they're with one provider that integrates all of their care. And again, so what does that mean? Making sure that you're establishing a good relationship between the patient and the provider. Remember that people of trans experience have very challenging situations with accessing gender affirming healthcare, and that many of them have had very, very, really bad experiences in the healthcare system trying to affirm themselves. So make sure that you're sensitive to that. Refer to the patient by their preferred name. That should be in all of your electronic health records. If it's not, ask them what is their preferred name. They will let you know. At the same time, you can ask them what are their preferred pronouns. If you're unsure or if you don't ask that, always use they. They is universal and it goes well. And then make sure, again, you have gender relevant patient education and health promotion available. And, above all, not only you, but make sure that your staff, the people that your patient sees before they see you, are respectful. Refer to them by their preferred names, use their preferred pronouns, make them feel welcomed and affirmed, and do not allow them to be in a situation where they feel any kind of microaggression or macroaggression towards them for being a transgender person. And so how do we do that? How do we make sure that we have an environment that's open and accessible for people of trans experience? Make sure that you have, an all gender restroom that's gender neutral. That's very important. Make sure that your providers and the staff are knowledgeable and that they're respectful of the individuals, not just of their gender identity, but also their cultural identity as well. Oftentimes, people of trans experience have other challenges that are related to their cultural identity when accessing gender affirming care. Make sure, again, I can't overemphasize making sure you use preferred names and pronouns. Make sure your staff are educated about gender affirming care and what that means and the importance of affirming people that come through the doors to seek care. And then again, making sure that you have intake assessment forms and that your EHR is friendly for people of trans experience. And so providing HIV care within a gender affirmative care setting may also have a lot of barriers. And what are those barriers? And then as well, conversely, what are the facilitators? And so for a lot of people of trans experience, particularly if they're living with HIV, they are very concerned about their confidentiality, particularly young people. They're very concerned about being outed, about either being trans or about living with HIV, or oftentimes both. Stigma is a huge issue, both in people of trans experience and those who are not of trans experience. Living with HIV itself is very stigmatizing for these individuals. You want to be sensitive to that. And then most importantly to me is prioritizing the transition and related care and make sure that their priority is your priority, not your priority being their priority. And we'll talk a little bit about that as we move forward. And then concerns about drug-drug interactions between antiretroviral therapy and hormone therapy is germane as a discussion. If people of trans experience think that there may be any interactions with their antiretroviral therapy that may harm their hormone levels, they will opt not to take the antiretroviral therapy because for many of them, their gender affirmation and the hormone therapy that comes with that is priority. So again, make sure you have those conversations and address those issues or concerns up front. And then again, facilitators, we talked about being integrative and providing HIV care and gender-affirming care within one setting. And then meeting their service needs. Make sure that you understand the social determinants of health. Oftentimes, these kids have what I call the 4 U's: unemployed, unstable housing, uninsured, and substance use disorder. So make sure you address those as part of your meeting their service needs as part of your intake assessment with these young people. Address the 4 U's. And now I'd like for you to hear from one of my young patients who was diagnosed as a teenager who is of trans experience.
My name is Jessica. I'm from Clinical Care Options, and this patient has asked that I read their testimony in order to protect their identity. Here's what they had to say. My doctor is one of the best things that's ever happened to me because she really had an impact on my life. Honestly, I'm not sure that a lot of doctors are like her because when she had transferred to a new office, they gave me someone else, and I was just so uncomfortable with that. They didn't even tell me, but I was like, no way, I have to go right back to my doctor. That's the only place that feels safe. She's the only person that made me feel safe. My doctor makes me feel safe because since the day I met her, it was a perfectly safe environment because she was very reassuring. She took me into her arms and was very caring. You wouldn't imagine just a random person doing that. And while she explained to me how the HIV pill would work, she told me everything's going to be okay. She keeps up with me all the time. You know, we have a good relationship. I love talking with her. And not only is she my HIV doctor, she's also my hormone therapist. And so she just explains everything so perfectly. She just told me about the pills and everything. When I'm there, the first thing she does when she sees me is give me a hug, which is wonderful. But I think she really does that because she really genuinely cares. Like, it's not just giving a hug because this person is going through something. It's like when you really care for someone, your life it changes and it's good. It's a good thing. Those kind of changes are good. And every time I go there, what keeps me going back is her, you know? She explains perfectly what she's going to do, what we're going to do today, what we're going to cover, the levels of my HIV medication and blood, everything. She covers that all, and it's good. It's helping me learn, and it makes me do research a lot because I'm going to go for biology in college.
So now let's just talk a little bit about gender-affirming hormone therapy. We see for feminizing regimens will involve estrogens or estradiol preparations as well as androgen blockers. And you see under the feminizing regimens, the estrogens, we have estradiol tablets, patches, and then conjugated estrogens for injection use. And then androgen blockers, we primarily use spironolactone, but there are other androgen blockers that you can use as well. And then for masculinizing regimens, we see the testosterone gel, cypionate injection form, and there's also testosterone patches to use as well. So for potential drug interactions between ART and gender-affirming hormone therapy, ARVs are unlikely to impact gender-affirming hormone therapy. And it's really important that you let your patients know that if you want them to successfully be virally suppressed and durably virally suppressed. So potential effect on gender-affirming hormone therapy, you see the ARV drugs listed there, and that gender-affirming hormone therapy that may be affected by ARVs, none, and that the clinical recommendations are that there's no need to adjust doses, and that if you need to titrate doses based on desired clinical effects and hormone concentrations, that you monitor them closely to do so. But you can see here, and I think it's important to let them know that taking antiretrovirals is safe, it's effective, and that also I try to marry the conversations that if you want to be really transfabulous and you want to be the best person that you can be, that it's important that we keep you virally suppressed and that taking your ARVs daily as prescribed is extremely important. So potential drug interactions between ART and GHT ARVs that may impact feminizing regimens, I would just like to call your attention to ARVs that may decrease concentrations of gender-affirming hormone therapy. And as you see the category of drugs, there are protease inhibitors. Particularly in my young people, I try not to use protease inhibitors. There's no reason to use them. And again, remember, if they have any idea that they're on antiretrovirals that may decrease their hormones, that they're likely not to take those ARV drugs. So be aware of the drugs that are listed here that may have some impact on estradiol levels, and that if that's the case, if those are the drugs, though, that may be best for that individual, that you explain to them that you'll likely have to increase their doses of gender-affirming hormones to make sure that they still have the desired effect. As long as they understand that, you win and they win. But if they think that there's some interactions there that there's going to be decreased and you're not going to be able to help them maintain their feminizing regimens and have the outcome that they desire, they will not take those ARVs. And then there are ARVs that have an unclear effect, and that would be, you see the combination of elbitagovir and cobicistat as well as a PI and cobicistat. And again, no reason to use PIs in these patients, even if there's a potential of an effect on their gender-affirming hormone levels. Potential drug interactions between ART and gender-affirming hormone therapies that may impact masculinizing regimens. And you see there the potential effects on gender-affirming hormone therapy, ARVs that may increase concentrations. You see the combination there, very similar to what we saw, but instead of increasing the combination, instead of decreasing that we saw in estradiol, these may increase the concentrations. And that's elbitagovir, cobicistat, and also all boosted PIs. And again, particularly in young people, there's no real reason to use protease inhibitors if you don't have to. But if you need to, if that's what's best to keep them virally suppressed, make sure that you monitor those testosterone levels and that you adjust them accordingly based on your levels that are achieved. And then there are ARVs that may decrease the concentrations of testosterone. You see them listed here, the NNRTIs. And again, adjust your testosterone doses accordingly based on the levels and also on the preparation or the formulation that you're using for their masculinization. Laboratory monitoring for gender-affirming therapy is extremely important to make sure that patients have the desired clinical outcome, physical outcome, with the least side effects possible. And I try very hard to make sure that I integrate the lab monitoring for their gender-affirming care along with the lab monitoring that I need to do for their HIV care as well. So initially, when we start out, just as we do with patients who are newly diagnosed on ARVs, initially every 2 to 3 months for the first year, you want to make sure you monitor them closely. And then depending on how well they're doing, how stable they are, after that, once or twice a year may be all that you need to do, the same that we do now for patients living with HIV, twice a year. Viral load and CD4 counts, if they're doing well and stable, is all that's necessary. We're talking about monitoring. What we monitor depends on who we're providing care for, right? So for transgender women, we want to make sure we monitor estradiol levels closely. Serum estradiol levels, we want them as close as in transgender women to the levels that we normally see in cisgender females. So you want to make sure you monitor their serum estradiol levels as well as their testosterone level. Be careful with the testosterone level. Again, here, it comes into play making sure that you know exactly what your patient's goals are. Some transgender women want to still have erections. It's important for you to know that. It's important for you to ask that because that will determine what type of testosterone levels you're trying to have. You may want testosterone levels higher than 50 nanograms per deciliter if those patients want to maintain erections. So make sure that you ask that of women of trans experience. And then again, because many of them will be on spironolactone for their androgen blocker, make sure that you monitor serum electrolytes. Prolactin levels, I don't do. There's no real reason to monitor them, but they are part of most gender-affirming guidelines. So I included them here, but to let you know, generally I do a prolactin level at the onset when I'm doing all of their baseline labs, and then I never worry about it once I start their therapy. For transgender men, serum testosterone level, you're going to monitor closely. And again, we want to aim for the same kinds of levels in transgender men that we expect to see in cisgender men, which you see there between 400 and 700 nanograms per deciliter. But what I really want to highlight here in big, big, bold letters is to make sure that you monitor hemoglobin and hematocrit very closely in transgender men. Why? Because remember what testosterone does. Testosterone stimulates erythropoiesis. And so oftentimes you may get polycythemia in these patients, even if they have therapeutic levels of testosterone, or even if their levels are low, you may still see increased erythropoiesis to the level that may cause polycythemia in these transgender men. Make sure you monitor that closely and then adjust your therapy accordingly. So viral suppression among transgender adults and adolescents in Ryan White HIV/AIDS programs. Remember, our patients who are fortunate enough to receive their care through Ryan White programs overall have a higher viral suppression rate than those who are not in Ryan White programs or do not receive their care through Ryan White clinics. So overall in Ryan White programs, we see about an 85% viral suppression rate, when in overall Ryan White programs, we see about an 89% viral suppression rate. So it's pretty good. But if you look over at the categories of trans individuals by age, and also, again, MIU, unstable housing, if you look at that, you can see where there is some disparity in achieving viral suppression, particularly if you look over to the right where we have unstable housing. Remember, that was one of my 4 U's. They have very, compared to overall transgender individuals overall, viral suppression rate is somewhere around 72%. Also, those individuals that are less than 24 years of age also have a lower viral suppression rate. So make sure that you pay attention again to their social determinants of health, and particularly in those younger trans individuals, they're often in unstable housing situations, unemployed, uninsured, and have some sort of substance use issue. So make sure in the younger trans adolescents that you're addressing those particular social determinants of health. They do impact their ability to become virally suppressed and remain virally suppressed. And again, prioritization of transition-related medical care over HIV care. Make sure that their priority becomes your priority. Often in individuals of trans experience, the HIV care is not their priority, but their transition is, or their ability to access hormones is a priority. Make that your priority. Once you are able to do that, you are often more successful in getting them to start antiretroviral therapy, remain on them, keep them in care, keep them virally suppressed. So back to our 22-year-old. So, to recap, she comes in for general primary care. She lets you know she's on oral estradiol. She's pretty good, but then she tells you that she's out of her long-term relationship and that she has sex with cisgender men and she's anal receptive. And remember what I told you about trans, particularly young trans people, they're often unemployed. They're often uninsured. So they're less likely to seek health care. And when you're uninsured, you're less likely to want to receive sexual health care or unable to receive sexual health care. And when you're unemployed, a lot of these young people may have what I call survival sex to make ends meet, to make sure they can buy food, to make sure that they can pay rent. They may have condomless or inconsistent condom use when they're having sex. So please make sure that you address that. Make sure that you let them know. It's important that they understand what kind of sex they're having and who they're having sex with so that you're able to provide them the best protection possible. And so remember, our young lady, she came in for routine care, otherwise was doing well, did not expect to be HIV positive. But now you have to tell her that she is now living with HIV when she's coming in just for routine care. So we're back to our young lady. So again, remember what I said with her. We want to offer her rapid start just as we would any other patient. So we want to make sure that we give her comfort, and the fixed dose combination pill that we recommend for her is going to be safe and effective and not have an impact or a negative impact on her hormone level. And so what are the questions she's going to ask? Make sure you have those answers. Again, and I will repeat this no matter how many times you say this medication is safe and will not impact your hormone levels, they're going to need to be reassured that that is the case. So they may ask you that question even after they've started antiretroviral therapy. And again, they're going to want to make sure that their current dose of their estrogen, in her case, she wanted to make sure that she could still stay on her same dose. She felt like she was doing well. She was happy with her feminization on the 4 milligrams of oral estradiol. So you want to give her comfort that she can continue taking that. Of course, in the media, all over social media and everywhere else, the potential side effects and possible side effects of some of the antiretroviral regimens that we use are posted everywhere. And so she tells you that she's heard about these medications and that she's worried that they may cause bone problems. And she may also want to know, does she need to worry about that? Again, make sure you address that with her. She's on TAF. You can give her some comfort in knowing that the TAF-based tenofovir regimen is less likely to have any adverse effects on her renal function or bones as well, and that she doesn't need to worry. Also, let her know you will be monitoring her closely so that if there's any potential problems that you detect, that you would definitely address those and make any adjustments in the ARV therapy if necessary. Key take-home points with transgender individuals is that we should provide care within a gender-affirmative care model. I like to call it an integrated model where they're receiving their gender-affirming care as well as their HIV care in the same place, and that you've addressed drug-drug interactions between their gender-affirming therapies and their ARTs, and that you will monitor them closely if there are any drug-drug interactions noted or if there are any clinical symptoms that she may express to you, that you will make the adjustments if necessary. And then make sure that you have appropriate support and referrals to address the other issues, particularly in young trans individuals of color. The social determinants are really impactful on their ability to access antiretrovirals and remain undetectable. So again, my 4 U's in this group: uninsured, substance use disorder, unemployment, unstable housing. Please make sure that you address those specifically because those social determinants of health are very key in making sure that this particular group of individuals are able to adhere to their regimens and medical appointments. Could go online for more CCO activities on key decisions in HIV care, medical minutes and podcasts with expert faculty, and clinical thought commentaries from physicians and patients, and also access patient education sheets to print and share.
Thank you to Dr. Collins-Ogle, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.